Hi everyone, today we will briefly talk about JAK inhibitors. These are new groundbreaking therapies for patients with inflammatory rheumatic diseases. Today we will briefly discuss about different aspects of JAK inhibitors. JAK inhibitors are highly effective oral option for inflammatory arthritis. JAK inhibitors have shorter half-life, allowing for more rapid adjustment when treatment must be paused or changed, such as in case of infection, surgery, or planning for pregnancy. They have a rapid onset of action, and usually patients feel better within 2 to 4 weeks. They inhibit a number of other cytokines, but they do not block TNF receptors. As a result, they do not cause TNF inhibitors associated issues such as congestive cardiac failure, psoriasis induction, SED type syndromes, or demyelination. They can be combined with other DMARDs or can be given as monotherapy. They are non-inferior or superior to gold standard, but there is no head-to-head trial, and mostly the data is coming from indirect comparison, and it is having comparable ACR responses. It is difficult to distinguish between the efficacy of pan-JAK inhibitors and selective JAK inhibitors. JAK plays a role in regulating cellular proliferation, differentiation, and immune cell function. JAK family contains JAK1, JAK2, and JAK3 enzymes, and STAT family contains 7 transcription factors. JAK inhibitor work by competitively binding to the ATP binding site on Janus kinase enzyme, preventing them from phosphorylating STAT proteins. This action blocks the JAK-STAT pathway, result in reduced inflammation and immune responses. Since the approval of Tofacitinib for patients with rheumatoid arthritis in 2012, the arsenal of JAK inhibitors available to rheumatologists has grown, along with the new indication, and they are licensed for different other conditions. The common JAK inhibitors include baricitinib, Tofacitinib, filgotinib, Upadacitinib, and these are the other indications apart from inflammatory arthritis. Safety is similar to other biologic. Serious infection rate is similar to other biologic. Serious infection is increased in patient with comorbid condition and patient on glucocorticoid, and in such cases JAK inhibitor can be stopped. Risk of herpes zoster is 2 times increased, and it is advised to vaccinate the patient with zoster vaccine. There are concerns over cardiovascular safety that resulted in post-marketing surveillance study by FDA. Oral surveillance study has raised concern of increased risk of malignancy and major cardiovascular event. Cardiovascular risk is high in patient with comorbid condition, patient over the age of 50, those who are smoker, raised BMI, hypercholesterolemia, hypertension, and diabetes mellitus. FDA want to be mindful of comorbid condition and advise to consider alternative biologic therapy in patient with high risk of cardiovascular morbidities. Cancer risk is increased in patients with rheumatoid arthritis, but there is no access risk with anti-TNF inhibitor. FDA warned that patient over the age of 65, smoker and ex-smoker, and with other malignancy risk factor, for those patients we should consider other alternative treatments such as anti-TNF therapy as a first-line therapy. Venous thromboembolism, DVT, and pulmonary embolism risk is more, especially in patients who are obese with previous history of DVT or PE or after surgery. JAK inhibitors are contraindicated in patients with severe active or chronic infection, current malignancy, pregnancy, and lactation, severe organ dysfunction such as severe hepatic or renal disease, and patient with recurrent venous thromboembolism. Patient before starting JAK inhibitors should be screened and a thorough physical examination should be taken. Minimal laboratory tests include hepatitis B testing, hepatitis C testing, HIV, and TB screening as per the national guideline. Patient should be assessed and updated about the vaccination status, and we should consider risk factor for venous thromboembolism. Minimal laboratory monitoring is advisable after 1 month and 3 months after starting JAK inhibitors. Then periodically, such as every 3 months, lipid level should be checked after 3 months of starting JAK inhibitors. Annual screening examination is recommended to look for any evidence of non-melanoma skin cancer. Patient should be evaluated using a validated disease-specific measures of disease activity. Thank you.